I'm giving examples. For example, now we are working in terms of, sectors. The telecom, we have already solved it. The innovators, they have sandboxes. We have the Tanzania Telecommunications Regulatory Authority. They have a sandbox where innovators can test their innovations for 6 months for free. And these innovations in telecom, they support all sectors. It could be in ICT, in health, in agriculture, all of them. So we have that sandbox. We have the fintech, we have the BOT, I think they have the sandbox, NMB. Recently, we have been discussing with the IHI. They have a hub there working with the medical devices to have another sandbox specific for health. So TMDA, we are meeting, I think, next week to have a sandbox rated for healthcare. Kwa sababu we have innovators, some of them supported by the government. They have products or services, but then they find it difficult to get approvals, accreditation. So we are working with the TMDA to have local sandboxes to test their products and services so that they can be certified. The ecosystem is growing. We have not yet reached where I want to be, but it is growing. So in the same spirit, laying down conducive environment by the government, we are working, with the universities. As I said, we have a Buni hub at Costec, was the first hub in the country. Then it changed to be a mother hub, now supporting creation of other hubs and supporting them in order to deliver the services required by these hubs. So in the universities, they have programs which support innovations, but they have innovation hubs in the universities. And when they have the hubs, then they support all the sectors, including the health sector. Nafikiri a few examples, if you see UDSM, SUA, Nelson Mandela, the support is very much growing. But already introduced here, Jumane Mtambarike of Sahara Ventures. Jumane was the first hub manager of Costec. So he grew up and moved on. So the ecosystem is growing, and to a large extent, including the private sector. Today we have Vodacom here with the Afia Pass, but Vodacom have been supporting, they have an accelerator program for innovators. That implies that, the private sector also are part of the ecosystem, and they are supporting the ecosystem. So you have Vodacom, you have Airtel. They had the Airtel Full Sarabu working with the Costec, Tigo. But when you go to the banking sector, we have NMB, they have the sandbox. We have CIDB. 2 years ago, we partnered to have the Embedded program supporting the innovators and the startups. Stanbic. So you can see also private sector, they are parts and a parcel of this process. First of all, they support the ecosystem, but they consume the innovations. So that signifies the ecosystem is growing. And we want it to grow further, but also we have investors, local and international. In June, I was invited to launch a study, which was, the study was known as, I think, looking into the local angel investor landscape. That signifies that, even we have local investors who want to venture to invest in the local startups. So that one, it is growing. On the other idea was kind of, the innovation spaces, those spaces. As I said, we have a Buni hub. Less than 15 years, from 2 hubs to more than 50 hubs. all over the country. Kwa hiyo, it is growing, but we need more, even more hubs. Kwa sababu when there is innovators at the local level, we wish that the local authorities could be able to give the first support before we come to the regional universities and whatever. But another part, already I said access to funding, because funding is a key issue in the ecosystem. Also, I think for the last, not the last, since 1991, COSTECH has been funding research and the technology. Technology means innovation inside. So we have been funding grassroots innovators. We call them local innovators. But for the last 8 years, we have Makisatu, which is the national innovation competition, where we have innovators from all sectors. They get support, technical support, but also they get initial funding, seed funding, and then the market take over. So that signifies that access to fund is not yet the way we want it, but at least the government has shown the way, and now there are programs which are supporting the access to funding, including Funguo of UNDP. So yes, it is growing. But I think I was also supposed to touch upon challenges. From where I'm standing from the government, our role is to provide the condition environment, so removing the challenges. But before I came here, I tried to check others, what are they saying about the challenges on the innovation ecosystem of Tanzania. So I asked the ChatGPT, what are the challenges of the innovation ecosystem of Tanzania? And they said infrastructure, talent and skills gap, regulatory environment, and access to funding. So there were 4 challenges which I saw on the internet about the ecosystem. But as I'm saying, for the infrastructure, the government, is extending the ICT backbone to the district level, but also the ICT Commission is establishing 8 centers, I think now. So the government is working hard to to reduce that infrastructure challenge, but at the same time preparing the people, the innovators at the grassroots level to be able to utilize that infrastructure. Because on one side, it is demand and supply. So in the cities of the infrastructure, because there's a demand. So in the rural areas, in addition to say lack of infrastructure, but are the innovators down there ready to use the infrastructure available? When we say talent and the skills gap as a challenge, the government is coming up to address it. I think you have heard that there is a new ICT university or ICT institute coming up in Dodoma to address the challenge gap. But last week, I happened to attend the Sahara Sparks event, where the theme was the people, skills, future. That means partners also are coming up to address the talent and the skills gap. So working with the government, the regulatory environment, as I said, we are providing sandboxes to being able to provide that condition environment to the startups, the innovators, to test their innovations before the market can take it up. Last opportunities, if I mentioned Makisatu, the government, in addition to putting on condition environment, but also we welcome collaborations. In Makisatu, coupled with Innovation Week, we run it, jointly with, partners. Before we worked with the UNDP Funguo but is open. If I mention last year, we had the WFP coming up, and they said, the innovators who have innovation in agriculture, we can take them up and work with them. So when we talk about partners, the main partners, at COSTECH, there are many ways we can work together. You can inject money to our national fund for advancement of science and technology. You can request taking the innovators and work with them, because in Makisatu, we have a platform where, we have innovators who are selected in all sectors. They go up the national level, and then they have to be now, when there is way, supported to realize the ideas. There are many ways of supporting them. So we invite collaborators to work with us in order to support the innovators. But also, as you know, the government now has a public-private partnership commissioner. That's we encourage PPP. That's also an opportunity. So wherever you see opportunity, talk with the government, we can work together. But lastly, this Friday, after tomorrow, we are launching the National Innovation Framework. So on Friday afternoon, it will be available online. The National Innovation Framework, it guides. It is a guiding document. So also is another opportunity to see where are we and where can you play the role. Otherwise, thank you na karibuni sana.
Thank you so much, Doctor. Thank you. I think that was very informative. Karibu sana. Thank you so much. I think questions will come.
By the way, I think I need to mention that there are a few innovators. We are talking about Uzazi Salama. I saw Mkanda Salama is one of the innovators who went through the Makisatu, the program I mentioned. There is Mkanda Salama, and there is Dao Mkononi. Also, I saw them on a program in another session. So these are the few products which came through COSTECH because of that condition environment. Asante sana.
Thank you. Round of clap to Dr. Nungu. I think most of us who are just getting in the innovation space, we are now learning on what is happening in the country. I didn't know that is the National Innovation Framework, but now we are learning so that whatever we are doing, we can be anchored to that framework. Thank you so much. So I think I want to be very nice and fair to my boss, Dr. Makwani. Just even 2 minutes of your time to greet us in this forum, because Dr. Makwani is the Director of Reproductive Maternal Newborn Child Health at the Ministry of Health, and he's our very close partner with the UNFPA, and of course with most of the maternal health partners. So just even 2 minutes, Dr. Makwani. Thank you so much for doing justice.
Good morning to everyone. Thanks for the first presenter, Director. Thank you very much for your enlightened policy perspective of innovation. Actually, I was writing a question to leave it behind because I'm running for another session. And my question is, as we've pointed out, there are many innovators with the wonderful innovations. And for me, as a director, I've seen very good innovations, ranging from the phototherapy machines, beds for the newborns, and others. They are very good, including the CPAP machines. But my major question is, what is the plan to ensure that there is a linkage between innovation and a wider scale production of that innovation? I think that linkage is missing, and I wish it could be part of the discussion here. I submit. Thank you.
Thank you. Thank you so much, Dr. Makwan. Oh, are you leaving? I hope, who is going to take note of the responses on your questions? Do you want me to give Dr. Nungu 1 minute to respond before you leave? German members, bear with me.
Dr. Makwani, thank you. As I mentioned, we are meeting TMDA. It is part of making that continuity. And specifically, CPAP machine. There's an innovator in Arusha. We supported it through Makisato. And he has a wonderful product. Then they went to TMDA for certification. TMDA said, they don't have the regulations. That's why we're getting a sandbox to make that one. Yeah. So from the government point of view, we wanted to connect. And the framework is kind of now pointing to each stakeholder that what is your law. For example, always I'm saying the government doesn't make business. Kosteki, I'm in a business of giving out money, but it's seed funding, every small amount, for the idea to take shape. After that, the market should take it up and take it forward. For the health and education, we have a challenge. Challenge is the regulator, they are not ready. I'm giving you another example, separate example. Tulifanya kazi zamani kidogo. We worked with the Hakika Fertilizer. It's a local company developing organic fertilizer. So now they are the one supporting the avocado farming. When the product was ready, TBS was not able to certify it. What we did, Costech worked with the TBS to draft the standard. So the same now we are supporting TMDA to have that standard to certify these local products. And at least, as I said, work with the private partners. Ifakara Health Institute, they are on board to support this. That's why I'm inviting more partners to work together. So from the government, we are ready. We say we put down in conducive environment, but sometimes we don't know exactly what the challenge is. So when we work together, then we know and work hand by hand to achieve it. Kwa hiyo, karibuni sana.
Thank you very much. I really wanted to hear that so that by the time Dr. Makwani, Dr. Makwani, do you hear me? You hear me? No? Okay. Thank you. No, I wanted to hear that before Dr. Makwani leaves, because I think this is one of the challenges that innovation in health are remaining to pilot. Pilot. Last week we had Jumanne with the Sahara Day pre-event. That was the discussion that there's a numerous number of innovation in health, but they remain to be pilot. They're not scaled up, you know. So I don't want to talk much because we need to hear from the other innovators. Now you have the message, and you are going to coordinate as well how to scale up the innovation that has been remained as pilot, so that we can improve the provision of health services. Thank you so much. Thank you, Doctor. So I would like to invite Jumanne, for I think he's going to use just 6 minutes, I guess. Yeah? No problem. So that now Jumanne is going to speak more of the innovation accelerator that was initiated by UNFPA, and we implementing to advance access to sexual reproductive health, particularly for young people. So this is an example and is a practical experience of how this has evolved, and some of the things that it has been said, they emerged from the innovation accelerator. Karibu, you have your mic.
Great. Do you have my slides? Don't worry, I'll use 6 minutes. Yeah, so good afternoon. This is still morning, it's too hot. An accelerator was, can we actually work with young people, especially from grassroots community, who understand the challenges that are facing young people, to come up with innovative solutions to address some of those challenges. And then that was the base of AMUA Innovation Accelerator. So ideally, what AMUA Innovation Accelerator does, we identify young innovators with solutions. We put them in a program called an accelerator to accelerate these innovations. We promote them through marketplaces by linking them to strategic partners and potential sponsors. And eventually we seed fund them by providing them seed fund to realize their prototype as well as MVP, minimum viable products. Next slide, please. So the way the program is structured, the first part of the program is what we call a challenge definition session, where we sit down with stakeholders to try to understand what is the exact challenge that we are looking to address. For example, one of the challenges that we're addressing back in 2016, 2017 was teen pregnancy. And then after the challenge definition, we do what we call problem validation, where we talk with different stakeholders to actually validate the problem statements. And then from the problem statement, we create what we call challenge questions. And these challenge questions is where innovators come in now through a hackathon to try to come up with ideas. And the ideas that seems to be more promising and practical, we put them in a program, it's called a boot camp, 14 days, to try to help them to do rapid prototyping. And after the rapid prototyping, we accelerate the solutions. And during acceleration of the solution, we provide them with some seed fund and also link them to strategic mentors and partners for potential growth. Next slide, please. So ideally, during the program, they will learn different skills that are required for them to be able to build their products. At the ideation stage, they will learn about ideation, problem solving, teamwork, creativity, and critical thinking to shape the ideas. And then at the MVP stage, they'll focus on product development, customer acquisition, business modeling, and try to test if their product is feasible, viable, and potentially scalable. And if it has a potential to move to the next stage, we help them to prepare some sort of an investment deck where they can move forward and try to raise money from prospective potential partners and investors. Next slide, please. So we have done 4 cohorts. The first one was Innovate for Sexuality. We did it back in 2016, 2017. Out of the graduates, 3 companies are still operating until today. The biggest one is TAI Tanzania. Last time when we were doing a traceability studies, they had employed 29 people, and they've produced multiple content, health content for different organizations, including USAID and others. But they were part of the program. And when we were working with them for the first time, it was just a team of 3 young Tanzanians who were passionate about health, who wanted to produce content and 3D animated content to cover health education. In 2017 and 2018, part of the problem identification process and challenge definition, we decided to focus on innovation that are focusing on people with disability. And one of the startups that is doing really good, it even went ahead and do partnership with MNOs, is Friendlycom, where they actually provide information to people with hearing impairment so that they can be able to access health services. But there are several other startups that emerge from that program. The third cohort, this is my favorite one, Innovate for Data Access and Usage. I was very happy to see AFIA Intelligence out there who are using analytics and AI to address some of the issues in the health sector. But also, for those who know, Salama was also mentored through this program. And then eventually now they have strategic partners and the team have grown. The last cohort we did in Zanzibar, we had multiple startups. One of them is Funzo, where they provide well-curated sexual reproductive health information to young girls. Next slide, please. So those are some of our portfolio companies. For those who know Salama, they're exhibiting somewhere. If you go to that booth, you'll be able to see them. You can see their works. You can see their clients and the project they've been able to do. You can see also AFIA Intelligence. I was very happy to see their new product, Dukadawa, the fact that they're still continuing to innovate. Happy to see one of the co-founders among the cloud. And also TAI Plus. TAI has been doing really good work to produce health content. So next slide, please. So basically, in terms of the impact, and this slide is just a summary impact of AMU Accelerator. First of all, before AMU Innovation Accelerator and Mawazo Challenge, there was very less involvement of medical and applied science students and young people in innovation. They didn't see innovation as their potential career option. They all saw themselves as doctors, pharmacists, clinical officers. They didn't see themselves as potential startup founders. But right now you can see a lot of young people who are coming from the medical sector also identify themselves as potential startup founders, whether it's Joseph from Dar Mkononi, and so many other young people are actually running these startup companies. And on the acceleration side, what we do is to provide them with the foundational skills so that they can be able to be supported. Some of them went ahead to be supported with programs such as Google Launchpad. Some of them have raised angel investment from network of angels such as Serengeti Business Angels. Some of them have formed big partnership with USAID. Some of them have been recognized and even took part in programs such as Chevening Scorer based on the work that they've been doing. We help them to build solutions. These solutions are still there, are being used, are being adapted, and are being scaled. We help to promote and showcase their work. As you can see, most of them are here showcasing their works. But also, most importantly, it's very difficult to monetize and commercialize health innovation. What we do also through our venture-backed acceleration program, we do matchmaking between them and prospective investors. I actually help them to meet investors that will fit and meet their investment thesis. And finally, we do nurture their communities. We have what we call Founders Meetup every last Friday of a month, where different founders and innovators meet to share experience, which in turn, young and emerging innovators and entrepreneurs can learn from the more mature one. So that is what we're doing with AMOA. There are some challenges, of course, the bridging fund to allow them to scale. COSTECH Director General Dr. Nungu said it already. You have issues with standardization and scaling. We like the idea of sandbox, which is a safe testing environment that the government is coming up with. And I'm very sure most of these innovators will benefit from it, because most of them, they were struggling with regulation when it comes to scale their innovations. Thank you so much.
Thank you. Thank you so much, Jumane. Round of claps, I think, is not enough. Thank you very much. So thank you for using the 6 minutes well. Thank you. I will do during the wrap up, we'll talk more of the AMOA accelerator. And I think I would like to invite Zabron to talk about the portable mobile learning system that is also a product of UNFPA, which also started in 2014-15. Is Zabron here? When we launched with the Minister of Health. So we'll talk more. 6 minutes, Zabron, I think is enough for you. Or 5 minutes?
5 minutes.
5 minutes. Thank you very much.
Good morning, everybody. Yeah, the slides, please. 20 sites, which was now 36. This is on the mainland side. But also we have 10 sites in Zanzibar. So total now was 46 up to now sites. And more than 10,000 users benefited from this innovation. Next slide, please. This is the distribution of this portable projector supported by UNFPA. These are the regions and the number of projectors they have up to now. And the implementation, I said, is nursing training institution, but they are using a cascading approach. They allow the teaching hospital or the teaching facility to use the projector, because those modules are more of practical-based modules. So the staff at the clinical area, they use the module, and also the pre-service one, they use the module. And when we do a monitoring visit, we conduct it for both sides, the teaching hospital and the training institution. Next slide, please. Yes, one of the factors is the training institution were not only the public, we included the private and the public. So we got good buy-in from the government. So the government, through the Ministry of Health, supported this innovation, and that's why you can see UNFPA were able to support the more 20 kits. Next slide, please. Yes. The positive impact of this, the first is the buy-in from the government, but also the modules were attracted by the Rwandese. Rwanda, UNFPA visited Tanzania, and the UNFPA Tanzania demonstrated this one. They were attracted on this innovation. So the modules are in English, and in Rwanda they are using French, so we have to go to Rwanda and implement the French one, meaning that we converted the English modules into French, and that was successful. Coming back to Tanzania, also we asked the same question on the sites. Would you like to be translated in Swahili? The answer was yes, although I will talk later about what was the result. So we translated in Swahili these modules. So in those kits, you have two versions. You have Swahili and English. Next. The challenges. Yes, go back. Next. Yes, the challenges. The first one was the Swahili one. After spending all the time to convert the modules into Swahili, back to implementation, it looks like the Swahili we used is very difficult. So English is simpler than Swahili. So, but also the motivation of using technologies and navigating the modules on some of the staff was a challenge. And some of them of this technology, there's a lack of confidence. And this was ongoing support to make sure the buying is continuous. Next slide, please. So the lessons learned, we found that, and this was from the users or the implementing, that this is a cost-effective solution. Always e-learning, you compare, and one of the study was done to compare a face-to-face and an e-learning way of training is much cheaper compared to face-to-face. This projector is about 500 to 700. That's the cost of buying this projector. So, and most of these training institutions, they say, yes, where can we get this? And then we buy our own. In remote areas, the kit is very useful because it can store charge. Even if you go, the hospital they were using in the community outreach where there's no electricity at all. And we supplied this kit with a chargeable battery plus a solar panel. So you can, when it's new, it takes more than 10 hours. You can spend 10 hours delivering your content without the charge going off. Later on, you can charge using your solar if there's no THS power. But also, the kit showed that there's a potential of whatever you want to share in a wider scale. You can use it by loading that content. Currently, I said we have only 10 modules, but yes, from this forum I can expect we can have more modules from other partners so that we can scale. Because when we are doing the monitoring, one of the questions they said, we have covered all of this, so what? So they ended up using the projector for other sessions of normal classrooms. Next, please. So the way forward is, they said, there are few kits. You can see one institution, one kit. And they can have 10 classes or 6 classes. So they are competing each other. They need more kits. But the government has got a national e-learning platform, which, as I said, it has got an Android, so we can integrate this technology with the national e-learning platform, which provides a continuing professional development for healthcare workers, and also can ease a way of tracking who has taken this module and to see if there's a skills impact. So more content can be developed, uploaded on the national e-learning platform, and then integrated with the PMLS for scale up. Yes, what we found is the solution has got impact, and currently we have 46 sites. They reported that the kit is fault. I have only 2 sites out of 46 that the battery is off or is not powering on. So the defect kits. From 2016, only 2 kits. Next slide. So that is my 5 minutes. Thank you very much.
Thank you so much. Round of claps to Zablon. Thank you. I think, as I said, we are going to spare like 10 minutes at the end for people who want to show the best pool, want to show the mobile learning system, how it works. And then those who want also to learn about the AFIA pass more than what the presenter will do. We have some 2 tables there. We're going to spare like 10 minutes. So let me welcome Melchizedek from Vodacom. I think 5 minutes, 6. Very brief, 5 minutes, yeah? Can I have the, sorry.
Good morning. My name is Melchizedek. I'm from Vodacom. I believe you can hear me. Yes. Yeah. So as Vodacom, we are not only embracing the innovations. We are actually living the innovations, and we are no longer a telecommunication company. We are actually a technology company. So we've actually disrupted many sectors from the financial services, and apart from just disrupting them, I think the unique things about Vodacom is we've made it actually to scale those financial services. So we've done a lot in the space of M-Pesa. We have a lot of products. Space of the lending space, we've also disrupted group saving. Now we have a crowdfunding. So we have many services. So one of the sector also we wanted to disrupt is insurance. As we all know that insurance service is one of the least financial service used in our country. And one of the key challenge is most of the insurance companies actually, they are targeting the high income and formal sectors. So informal sector, which is a majority of the Tanzanian, they are actually ignored. So that is one of the things that Vodacom, we are actually addressing. So we are not an insurance company. We are working actually with an insurance company, but we are not actually distributing the traditional product. So what we do is we design the product based on our customer need. Because as a Vodacom, we have the data, we have the customers, we understand our customers. So most of the solution actually, they are tailor-made to meet our customer need. So as a Vodabima, we are a digital platform providers, and our customers can only access this insurance product through our digital channel. So we have a USSD, you can access insurance services. We have an applications, and also you can access our service through a web. Next slide, please. Yeah, so one of the key challenges before coming to this space is that there are things that we need to address, and one of them is accessibility. One of the key challenges that people cannot easily access these insurance services. Yeah, because from the traditional space, you have to go to the insurance broker, which actually they're available in cities, or you have to go to the insurance company, or you have to go to the insurance branch. But with us is only to have your mobile phone. Yeah, so one of the key barriers that we're addressing is actually accessibility. The other one is affordability. So affordability is first we design the product that are very affordable, but secondly, we provide flexibility in payment. So flexibility is, we have 2 solutions. One is saving. So we are allowing our customer to save slowly and pay the insurance. Because from the insurance regulation, you have to pay your insurance once and your premiums. Yeah. Which, if you go to the informal sectors, that is still very expensive. So they need a flexibility. So one is we are promoting the saving, But also we have an insurance premium financing. So we are providing a small loan with a very small interest, and then we pay the full premium, and then we allow the customers actually to pay slowly. But also we know one of the other barrier is education and awareness, because insurance is not a tangible service. Yes, we are selling the promise. So someone is paying their premium, but you're not getting anything tangible until the event happens. So a lot of education and awareness actually is required so that people can understand the value of insurance. So that is what we're doing. We have above the line, below the lines, influencers, and actually this is one of the areas that we actually partnered with UNFPA on how can we provide or come up with a very innovative way of providing awareness and education so that these people can understand the value of having insurance. Yeah, so these are the key things that as a Vodacom we are addressing so that we'll be able to scale the insurance. Next slide, please. Yes, of course, this is our journey. So we do all the products from motor, life, and health insurance. Next slide, please. Yes, so I want to expand more about this health insurance, which actually is what we partnered with UNFPA. So we've designed a very affordable health insurance, which is actually very affordable, very flexible. So flexibility is customers can pay 6 months, 3 months, or annual premiums. But also it's very reliable. We have more than 500 healthcare providers countrywide. But also it's very simple. We've tried to digitize because we understand Vodacom customers, they're everywhere. So we want when you purchase insurance, you can just have simply your membership number and access service. Yeah, because currently people want physical cards. Yeah, so it's very difficult actually to distribute physical cards countrywide. And of course, this is one of the areas also we are struggling currently because most of the people still believe my health insurance is my card. If I don't have a card, I don't have a health insurance. Yeah, so one of the things that we're advocating is that you don't need to have a physical card. You just need to have your membership number. You go to the health facilities, you're verified, and you access the service. Yeah, next slide, please. Yes, so among the innovative features that we've designed in this solution is first is customer, apart from being able to purchase insurance, they can actually save, they can actually view the benefits, they can actually find the facility in the menu, they can actually request for a treatment. Yeah, so these are the, you can also buy for a friend. We know many people, we have in our family, maybe we are, our employer have provided us with insurance, but we can still buy for our other siblings. So we have a buy for a friend feature. So next slide, please. Yes, yeah, so speaking about our partnership with UNFPA, because we understand having a health insurance automatically will address a lot of challenge when it comes to maternal services. Yeah, because I think 95 or more than 90% of the challenges in the maternal services is related to cost, that people can't afford or they don't have a means actually to cover those costs. So having the insurance will address those from the pre, post, and also during the maternity. So our partnership with UNFPA is, despite that we have actually subsidized, we have actually come with a very affordable product. Still, most of the customers still feel it's still expensive. Yeah, so we've piloted this service in Temeke with UNFPA, in which we have subsidized the premiums. So actually 50% of the premiums have been subsidized by UNFPA, and we are targeting women only in reproductive age. And another thing is we've partnered is education and awareness, joint effort. So We've done a lot of effort since January with UNFPA. We've done a couple of the roadshow in Temeke, forums. We went to the local governments. We went to hospitals to actually educate these women so that they can have an insurance. Yeah, so I think that's all for my presentations. We look forward, we'll have a desk there in case of more questions.
Thank you. Thank you. Round of clap to Melchizedek. Thank you very much. This is an innovative initiative that UNFPA and Vodacom, we have an agreement with them because one of the problem we have, and many people who understand or work in the health system, they know the higher out-of-pocket cost for accessing the maternal health care services. So we thought that how can we do it, at least to minimize. It was a pilot tested idea. It was a testing thing. So we have realized that it is working based on the very preliminary information and feedback from the people and also the community support from Temeke. So we are looking forward to scale up to the whole Dar es Salaam, but also to scale up to other regions when we have more funds with the Vodacom. And luckily that since we have a partner, Sahara, who is our lead partner in innovation at UNFPA, so we have this collaboration between Vodacom, UNFPA, and the Sahara. So thank you very much. My last and the only lady speaker, Agnes. Thank you very much. I would like you to clap for this lady. She has a lot to say. Karibu.
Thank you. My name is Agnes Ndunguru from Tanzania Midwives Association, and I am a midwife. So today I would like to share my personal experience on water birth services in Tanzania. So for over past 2 years, I've been attending water birth. And next slide. Yes, so eyes on the screen, please. It's a video. Yeah. We don't push in the water, we breathe out the baby. There is no pushing. So this is the first time mama, and I was her midwife. Yeah. The baby is out. Yeah, so the baby can stay underwater for 90 seconds. And that was her grandmother. She couldn't wait. She said, no, please, let me take my granddaughter. Yeah. So my water birth journey began when, like 20 years ago, when I was in primary school. I watched a movie and I saw a woman giving birth in the water. So I asked my father why the baby didn't die. He said it's because the baby lived in the water for 9 months. But I'm not sure if he was confident in his answer. I'm not sure. But that's how it is. Yeah. So next. There are 600 meta-analysis research articles on water birth, and I will share the QR code at the end of topic, so you will scan. And those articles shows that babies born underwater, they are at a very low risk of respiratory distress, and also there's another benefit that it's a reduced risk for obesity, allergies, and diabetes type 1. So in 2 years, I've attended 125 water deliveries, and I am a midwife for over 10 years now, and I attended more than 2,000 deliveries, but just 125 for water birth deliveries. So when I was in my working place, I realized that in Tanzania, we are lacking the options for childbirth. So I decided to get trained on water birth. Next slide. So as you can see, many women were prime gravidas. I think it's because maybe they're afraid of pain. And all these women were recruited from my Instagram page, known as Midwife Aggie. And we had 9 previous births for multigravida, and we had also a twins water birth and breech water birth. And also we had a vaginal birth after cesarean sections, which were 12 and was successful. Yeah. So as we know that the vaginal delivery is recognized as a safest method for childbirth and offering numerous advantages for both mothers and babies. So water birth also reduces the number of unnecessary cesarean sections. So in water birth, we have something called CPR, calm, peace, and relaxation. So when a woman is in the water, and if she has that CPR, it emphasizes those hormones which are the hormones which are used in the labor and delivery. Then those hormones are released in the body. So it shortens the labor and also reduces the needs for the interventions, as it's a natural process. And also it reduces the risk of perineal trauma because it's a warm water, and the position which a woman used in the water helps the muscles relaxation and also the buoyancy effect of water itself. It reduces the risk of perineal trauma. And the best thing is in the water we don't push, we breathe out the baby. Pushing inasababisha sana perineal trauma. Okay, next slide. So water birth services is very valuable options for the families and who are seeking natural birth. And the Minister of Health, please consider water birth as one of the method of supportive care and method for childbirth in our country. So I trained about 40 midwives here in Tanzania. These were the training at MUHAS. It was in June this year. And they were coming from different regions in our country. Next slide. I'm there with Barbara Harper. She is a founder of Water Birth International. She has trained more than 78 countries, and there is the QR code. Sorry, Barbara is a professor midwife. There is a QR code for the articles. You can scan and please read the articles. Next slide. Next slide, please. Okay, so you can follow my Instagram account, Midwife Aggie. I post the positive birth stories so that to inspire pregnant women and other healthcare providers to do the same. That was the twin delivery. If you see that smile on my face, know that the baby, I can see the baby's hair. Yeah. So this woman here, she was a prime gravida with 40 years old. That was her first baby. And that woman, a first-time mother with a companion. Thank you.
Thank you so much, Midwife Aggie. A round of clap to Aggie. She's the only lady in this forum, and I think she has shown you some of the exciting things in terms. Thank you very much, my panelists. Can I ask you for a few minutes if you can move now? At the stage, yes, so that we can have some questions. So, since I have few minutes, I will allow like 4 burning questions. Then they will be responded. Then some few minutes, those who want to ask more questions, there is the bus pool there. Aggie can talk more. There is the Afia pass will be there. The portable mobile lane system is there. So at least we have we spare 5 minutes for people to go and ask more in that. Who is going? So I've got, I said for now they're becoming 6. Then if there are 6 hands, then just 1 minute you ask your question. So we save the time a bit. Is that okay? Right. Thank you. Yes, yes.
Yeah.
Oh, yes, thank you so much. Dr. Felix Gundal, the Assistant Director in the Department of Reproductive, Maternal, and Child Health. I've heard the last presenter calling for the Ministry of Health to consider. Number one, I think we are going to give you a forum where we're going to, the technical forum, technical working groups, presentation for the further discussions. I think there is some of the issues need to be discussed. So for example, that the no issue, is it cut when you're comparing the norm or the full term versus the preterm, or the difficult labor versus the normal labor? All those need to be considered. The baby born sick versus the born sick normal. So need to discuss in technical forums before we consider further. That's
Thank
what
you. Thank you. Thank you very much. Yes, Dr. Sande.
Asante sana. My boss has spoken about the ministry. I want to go there. Sande Dominico, MPD Sarah Foko at the ministry, but also President-elect of Agota. So commendable work, all of you. Straight questions. Zabron, one thing that I've learned about this work, doing mostly focused on pre-service education. So I would like to learn if there is an opportunity to put it for the service, and I consider also the Christian cadres. And then to Agnes, very good work. A declaration of interest. I'm a founder. I'm a critic. I mean, serious interest on respective maternity care. So I love to see that. My question is, how much of this is institutionalized. I mean, if this is happening in a facility setting or at home, and if whatever the case is, I think the next very important step would be to register this intervention at NIMRI, and then do such something like a randomized study where you have 2 arms. Some of them will be going into the routine way and the other opting for the water bath. And then come the end of the day, you can come and say whether it's something that we may be able to take in the next forum, like technical forums, and agree as a national policy. Number 3, mwisho kabisa for the Voda Bima. Have you looked at how to explore the current wave of universal health insurance? Asante sana.
Thank you very much. My name is Mary Ngo. I'm from Amref Health Africa, Tanzania. And my question goes to the AFIPAS Voda Bima. I've seen the 70,000 per year. I'm just wondering, is it a flat rate for all kind of services? And if yes, is it also covering services for the health, for the child health? I was just wondering about that.
I think my panelists, you are noting the questions. Yes, thank you. No, sorry. I think that one.
Thank you. My name is Ivoni Kamala, Implementation Consultant with Lauda Global Health. I'm a very huge fan of what Agnes Nduguru is doing because I've done my dissertation on respectful maternity care. Agnes has a WhatsApp group with lots of women in Dar es Salaam and other parts of Tanzania where they discuss labor and delivery and remove the fear factor away from the birthing process. And I think that's the first step. Like Dr. Bundala said, there is science that has to go into that in our local settings, and I really support that. But speaking to Agnes, and I need to ask you 3 questions. Because we have giants stakeholders in these rooms, mothers, fathers, as well as the Ministry of Health and others, what are 2 of your greatest barriers in implementing water bath in Tanzania? But also, the last sentimental question, if you were not a midwife, what else would you be? Because I'm a midwife myself and you're doing great work, but if you were not a midwife, what else would you have been?
Thank you very much. This lady, and I think
Thank you. My name is Shuena Hafi. I'm a medical student from Kairuki University. My question is to midwife Agi. You talked about we are not pushing the baby. You breathe out the baby. So my question is, how do you control the urge to push the baby? How do you convince the mother not to push the baby? Thank you.
Thank you. Now the last one is Dr. Lipi.
And in that meeting we invited somebody from the Bakara Health Institute, which is also funded by UNFPA. So I believe they are the same material. And those materials can be accessed in the MCT and the Tanzania Nursing and Media Council, and you can access and do courses and get CPD. So then possibly there are issues of coordination. And probably we can need to work together so that we change our ideas. But my challenge, to have innovations and the animations and
my half minute
But my
has gone.
last question goes to Agnes. That should be mentioned. We need to discuss more of not water bath or reducing maternal mortality, but because of such there are a lot of issues.
Thank you very much. I have to send the mic to my panelists. Those with questions, half a minute. I think Agi, you have more questions or some comments. Then Melchizedek, half a minute, and Zablon, half a minute. And Zablon, half a minute. I'm not quite sure if there is also a question for Jumanne, Dr. Nungu. No? No, okay, good.
Okay, thank you very much for the questions. So I've received 2 questions for Voda Bima. So I think one of the questions is regard to how are we fit into this wave of universal health. Yes, Actually, we are in discussion with the respective institutions that actually driving this universal health, because we also want to be part of it, as we still believe for universal health to be successfully, as we still believe for universal health to be successfully, you need, you cannot deny the role of technology. The fact that we need to enable the citizen to access these services simply and everywhere and anywhere. Also providing the flexibility in payments. Yeah. So to assure you, we really look forward to support the government initiative to make sure that health insurance is accessible to all Tanzanians. Yes. So for the second question is, yes, we provide comprehensive health insurance, and it's covering inpatients and outpatients. And of course, as I said, we are targeting informal sectors, and we've accredited the facilities, the government facilities, that actually are also very affordable, because these services are accessed from the health centers, regional hospitals, district hospitals, and very few private facilities. Yeah, so for more information, I'll be there, and then I think we can expand further about the products.
Thank you so much. Just a small compliment on what Melchizedek has said. Why we partnered with the Vodacom is to ensure we address the third component of universal health coverage, because universal health coverage has issue of quality, issue of access, but issue of financial constraints, that we need to remove the financial constraint part of it. And if you read the Universal Health Insurance Act of Tanzania, it talks about involvement of the private sector, particularly private insurance.
As I said, is a practical based content, but the implementation was a vice versa. We introduced it to pre-service, we cascade it to the in-service. And the reason is clear. All of us, we agree. Product from pre-service, when you expose them to the practical clinical area, there's a huge gap. And this idea from UNFPA was, what would be the effect if we introduce this content based on clinical area when they're at school, and then at the same time giving those in the clinical area. Yes, the content is based on, are practical based. The second question was from Dr. Kipingu on the like there's a duplication of effort. Yes, I agree with you. There's a need, and actually, if you look at my slide, I urged about the government on harmonization or integrating this technology with the initiative where the ministry is supporting. Yes, we have 10 modules of the same from Japaigo that, and they are accredited by Medical Council of Tanganyika. So can be harmonized with these modules, and then maybe the effort we could add up more modules on that. And yes, they're outdated. We started in 2016. Yeah. They may need new technology, new skills of doing this. And I know Madam Felicity is here. Thank you.
No, thank you very much. But since we have no more time, but Agnes,
Okay.
Agnes, use just half a minute, and then since we have our booth there in this somewhere down there, I think the first Makia. Then we have our booth there. Everything is going to be there, and most of the panels, they are going to be there. So please feel free to visit the booth, and then you can ask more questions there. Sorry, because I'm being pushed by the next forum. Yes, Agnes, for half a minute.
Okay, thank you. I had a question from Dr. Sande. All these water births have been attended in the hospital, private hospitals. And the question from Yvonne Kamala, I was born to be a midwife, and I think I didn't choose to be a midwife, but midwifery chose me. Yeah, and my heart is very close to pregnant women. The barrier is from the healthcare workers. They don't believe if we can this service in our country, as they always say, this service is for white people, we are not developed yet, so that's it's a very great barrier. And okay, it's about pushing the baby. We train these women on breathing techniques, and they always feel comfortable when they breathe out their babies rather than pushing. Thank you. Pushing. Thank you.
Very much. Since we don't have time, I think my two panelists, you can just say goodbye. And thank you very much for everyone who attended this forum. You are really most welcome to our booth down there. And then we can speak more and ask more questions, discuss more how to move the innovation in the healthcare system, because I think it is time to go. It's time to move to that direction. So thank you very much. Can you clap, a big round of clap to my panelists? Thank you very much. Thank you, thank you, thank you. I think very much. Thank you, thank you, thank you. I think I'll have to hand over to the coordinator.